And now we'll hear from the stakeholders themselves. How do they see their responsibility in creating value for all patients? Can a balance be found between innovation and cost sharing that does not impact some consumers adversely? Please welcome on stage Kristen Bass, Chief Policy and External Affairs Officer with the Pharmaceutical Care Management Association, Dr. Suzanne Obrecht, immediate past president of the American Academy of Dermatology. She is also Chief of Dermatology at the Beth Israel Deaconess Medical Center and Associate Professor of Dermatology at Harvard Medical School. C.C. Connolly, President and CEO of the Alliance of Community Health Plans, and Robert Papavian, Vice President of U.S. Government Relations with Pfizer. Returning to the stage is The Hill's Editor-in-Chief, Bob Cusack. Back to you, Bob.
Great. Thanks, Jack. I thank the panelists for joining us today. A lot of healthcare expertise on the panel. Broad question, and Suzanne, I'll start with you. Why are some patients not able to experience breakthrough therapies?
Well,
and if you can describe your experiences with patients.
dermatology and rheumatology, actually studies have shown that we have the highest burden of trying to document our patients' needs. So patients have two problems. One is prior authorizations, and the other problem is step therapy. It's really hard for a patient. We prescribe a drug. In fact, a lot of times we call our prescription pads now suggestion pads. So we try and prescribe a drug for a patient, and we have to go through prior authorization. In my institution, my department, we actually hired a pharmacy tech whose full-time job is just doing prior authorizations for patients who come to see us. And that's patients they go to the pharmacy, they get the denial, they contact us, and then we have to go through a series of steps in order to get it approved. Step therapy is the other issue. It was discussed a little bit this morning, but step therapy means that a patient has to go through a series of drugs before they can take the one that the physician knows will be helpful for them. So generally they're less expensive drugs, but many times we know that they won't be effective. But patient has to go through those steps. And then they change insurance companies, and the insurance requires them to go back through the same steps. And sometimes we're unclear that we'll be able to take care of them even through those steps. So the American Academy of Dermatology, who I represent today, has a model legislation, and we're happy to say that it's been passed in the 20th state. If the governor of Virginia will sign the bill, that's the 20th state. But in 30 states and in the District of Columbia, there's no protection for the patient against the step therapy laws. So those are the two main factors that we find. It's very prevalent. We've surveyed our members. We have 20,000 members in the American Academy of Dermatology, and 9 out of 10 of our members say that they're unable on a regular basis to get for their patients the medications that they need. 38% of our members say they experience drug shortages, which is another problem. These aren't innovative drugs. These are things like lidocaine for local anesthesia for surgeries in the office. And we have real drug shortages in this country.
Cece, what do you think are the biggest barriers for patients, and what is the role of step therapy? I mean, cost is an issue in healthcare. It's going to be a cost for decades to come.
So I actually think there are a couple of simple notions that haven't really been raised very much in this morning's otherwise wonderful conversations. The first is price. Price is the problem. Price is the main problem when you talk about access to prescriptions today. Pricing of these therapies is a complete mystery. It is a total black box. I somehow have this vision of pharmaceutical company CEOs in their office throwing darts at a dartboard to land on these prices. I mean, that is truly how illogical and irrational it is. And we can pick any of our favorite examples. Insulin happens to be a great one right now, and we can talk about the cost of insulin these days. But There's another thing. If you really care about people in this country getting access to life-saving, innovative therapies, then you should be on the front lines of ensuring, first and foremost, that every single American has insurance coverage. Let's start with Medicaid expansion. You want to talk about low-income individuals in this country that don't have access not only to prescription medicines, but seeing a doctor, getting to a hospital, having lab tests, you name it. Let's get Medicaid expansion. Let's take steps to make the individual market, which does offer insurance to millions of Americans, let's make sure we get it as affordable as possible. Let's get our policymakers to crack down on the junk insurance policies that are now being permitted again in this country, where people have deductibles of $10,000 and don't really actually have any coverage. So I would like the conversation to come back a little bit to the pricing of the products. And also, if you care about access to innovation, pick up the banner for insurance coverage to begin with. That's the first step.
Robert, let's talk about price transparency, how important it is, and where the industry is on it.
Well, transparency, and just to follow up on your comment about pricing, for someone who has been involved in pricing and made those decisions and been involved in the calculation, it's not a mystery, trust me. There's a lot of analytics that goes behind that, and we'd be more than happy if you want to come, we can share it with you and show you how we come up with the price. So there's a multifaceted way of how prices are set, and it just doesn't have to be what you just said, which is the profitability issue. It's more than that. So happy to help out, but the price transparency is an interesting dilemma. So we, as an industry, are for price transparency, but we want it to be across the entire supply chain. It shouldn't just be upon the pharmaceutical industry to be transparent about their pricing. We should follow the dollar exactly where it goes throughout the supply chain. And we're for it, and that was something that my CEO and the other CEOs said at the hearing last week. So transparency is a good thing, actually.
And when you say across the board, you're just saying with all providers?
Let's be transparent across the board. So we're talking about the insurers, the pharmacy benefit managers, the hospitals, the pharmacies, the physicians, the academicians, the academic medicine, the brokers, you want me to name all of the people who are involved in the pricing pie? There's a lot of people who have their hand in the pricing issue.
Kristen, describe the role of PBMs, because that's been a hot topic this year, certainly, and will be so. Some in the administration have criticized the so-called middleman. Why are PBMs so important to ensuring access?
So what PBMs do, and I think a lot of people know this by now, but a lot of people don't, is negotiate with the drug manufacturers to try and get price concessions on products that manufacturers have monopolies on these products, brand products, and data exclusivity, and they can basically price at will. So our companies use market competition to get them to actually compete against each other when there are therapeutically equivalent therapies, drugs, to try and get price concessions out of them. Our companies also get the pharmacies to compete as well. And what PBMs do is they work on behalf of payers, meaning health plans and self-funded employers who provide health insurance. Nobody has to use a PBM. If PBMs didn't add value to the system and try and bring down costs for patients and for health plans, nobody would hire them. So basically, they are a subcontractor, if you will, to health plans. Health plans typically negotiate with doctors and hospitals to get their rates down. That's what PBMs do on the pharmaceutical side.
And how, I mean, with the healthcare system is quite complex, and I want to kind of throw this out to the whole panel. Suzanne, I'll start with you, just on the differences that you see in private insurance, Medicare and Medicaid, and what works and what doesn't, to get everyone's goal here is to get patients the medicine they need.
Well, you know, sitting in a doctor's office and writing prescriptions, if I notice what the patient's insurance is, I know sometimes whether I'll have more or less trouble getting the patient the medication or the treatment they need. So it's no secret among physicians which plans, it varies by state, but which plans we would prefer our patients came in on. I work at an institution where we feel like our mission is to take care of all comers, so that I'm probably not the best person to ask the question, because we take care of Medicare, we take care of Medicaid patients, and I'm pretty much blinded. It's hard sometimes to make the hospital budget, but that's how we behave. And is partly how we'd like to behave about the medications also, is that we wouldn't need to spend the effort that we do at the conclusion of the patient encounter wondering if we can get the patient the medication we feel would be effective.
Mm-hmm.
So, Bob, I do want to underscore that I think it's been demonstrated over and over again that physicians practice universally across the board by a patient. They don't change their practice based on insurance, and I think that's important for audiences to really understand and appreciate, and we see it all the time with the physicians working with our plans. But I want to suggest that there are some really good models out there today that I think deserve more attention and even, frankly, emulation. So, for instance, in the PBM space, and PBMs are taking a lot of heat at the moment because there are some PBMs that you don't fully understand their math either. But there are several PBMs today that operate in a highly transparent manner. You pay them an upfront fee to do what they do, which Kristen sort of articulated very, very clearly. And then any rebate is passed directly on to those consumers, 100%. So that's an interesting model where you pay them for the good work and important negotiating that they do on behalf of patients, but it's all fully transparent. If you think about our health plans, they have a particular model that they're very committed to, and it's an integrated, collaborative model with the clinicians, with the doctors, hospitals, patients, and communities that they serve in. And what we see over and over again, and the data bears this out, is that when you have that integrated model of the plans and the payers and the community all working together, you have much better health outcomes, you get much better value for your dollar. So we can see models around the country. You look at what Medicaid right now is doing in Hep C, which you were talking about. That's a pretty intriguing model because it's actually using the same number of dollars to get a life-saving therapy to more patients. I mean, that's the premise of your entire event today. So I think that there are some great ideas out there, but again, I'm gonna get a tiny bit on my soapbox. The prices are still too high, and the antics that go on around patents, I mean, you heard in the hearing on the Hill recently, it's Humira. They have 247 patent requests. Come on. I mean, seriously, you don't have to be a scientist to know that that is clearly an abuse. And it is aimed at hanging on to that monopoly and making as much money as they possibly can on that.
Can I just jump in?
Yeah. Kristen first, and then Robert.
This is actually just, I'm going to add a little bit onto the beginning of Cece's talk there, which was there are solutions that are out there that would help reduce abrasion in the system. One of the ways that our companies are able to negotiate price concessions is to set up formularies. And that's where all of you go, and your drug is either on the preferred tier or it's not. And that's one of the things that you're suggesting is problematic. There are tools now that are available to every doctor to use, to every health plan to use, that give real-time formulary information for every patient. SureScripts, which is the hub that runs all of the communications between the pharmacy and the PBM and the insurer, is able to provide at the doctor's office for the physician the ability to look up and tell the patient in real time. Has everybody adopted this yet? No, but as technology improves, an electronic health record that actually could track your prescriptions over the last X number of years would solve the problem of step therapy being a problem when you switch health plans, because there would be easy documentation that you already tried these other drugs. So there are ways of tapping technology to smooth abrasion and to make sure that people have access to medications, assuming, and this goes back to Cece's point, that they're affordable. And the reason that all of these systems have to use formularies now and have to use step therapy and have to use prior authorization is drugs are very, very expensive now. They didn't used to be, they are. And as consumers, we have to start with the most cost-effective medication before we move to the more expensive one.
Robert?
So a few things I want to address because you guys said a lot of things. So number one, about the PBMs. There are good actors out there. I agree with you 100%. The unfortunate part is that some of these good PBMs that are out there that are doing the 100% pass-through, only doing it based on fees, don't get any notoriety, the reason being that you have these brokers who have no incentive of selling those PBM models. So here, there are PBMs out there, find them, they do the right thing for the patient, and they're doing it. About the patents, I agree with you. I think there's a lot of gamesmanship that is going on. You heard about the CREATES Act. All those CEOs agreed that they would support the CREATES Act, which is an important step forward. But the biosimilars is a perfect example of how even when we have cost-effective, lower-cost alternatives, they're being blocked out. And why is that? Is because of the way that the system is set up. So, for example, if you look at the Medicare Part B expenditures, 4 out of 7, I think, top drugs have lost their patents already. There are biosimilars that have been approved by the FDA. Few of them are not in the market yet because there is litigation going on, but there are several that are in the market, but they're not being used. The question should be why. When you have a product which is out there about 30% less expensive in average sales price, and it's not getting any kind of utilization, then that means that the market is not functioning appropriately, where you are not using the least expensive medicine. Finally, I agree with what Christine said. Information is important, but that information should not come not only at physicians' offices, but also should come before the patient even signs up for a health plan. They should be able to tell, there should be transparency about when I go in and try to purchase a health plan, whether my product is covered, what is my out-of-pocket cost, whether there's step therapy involved, whether there's prior authorization involved, what physician is included in my network, what hospital I can get to. That information is very difficult to get. So one of the things that we need to do is put it very much upfront with the patient to have access to that.
Yeah, I think as a physician, it's really hard to see the patient in the office. I do use do electronic prescribing, and I'll put in my drug, and it'll give me tiers. But you know, if the marketplace is shifting so rapidly that may or may not actually reflect what the patient sees when they get to the pharmacy. And as you say, the insurance companies, you sign up in November, December, and they may change their policies by June, July. We have dermatologists who are dropped from roles in the middle of the year, and the patient has no advance warning of that. We know that actually the dermatologists helped bring this to federal attention, but we looked in Connecticut, and one insurance company said they had 100 dermatologists, and we found that 10 of them died, 3 of them aren't accepting patients anymore, and the other group were duplicated because they added. So the patient says the insurance company has plenty of dermatologists, but practically speaking, they didn't really. So there's a lot of transparency issues here, and more compatibility among electronic records would certainly help some of this, but it is not here today. It is not something that I can utilize to take care of my patients.
Well, and this is for anyone who jumps in, you can all tackle it. I mean, what are the solutions? Can it be a comprehensive solution? What is one thing you'd like to see Washington policymakers do, whether it's cracking down on junk insurance plans or something else, or do you think that this is going to have to be dealt with by providers, the states, and because there's so much gridlock, especially on healthcare in Washington?
I'll start. I think that if Congress could pass the CREATES Act and which is a bill that would make it somewhat harder for manufacturers to keep those who wanted to develop generics or biosimilars from getting samples of the product, which clearly you need to get so that you can develop the follow-on version. And stemming that abuse, which is increasingly used, would be helpful.
I completely agree with that. And we've now heard from the industry CEOs, we've heard from Democrats, Republicans, people in the administration, they all support it, so let's get it done, right? To your sort of larger question, Bob, I don't think that there's going to be one grand solution to this challenge. You know, as you underscored, healthcare is not only so complex, but it's personal, right? We talk a lot about healthcare not functioning like other markets that we're familiar with. And we can tick through all of the ways in which the healthcare market doesn't function like a market. And part of the reason for that is it's personal, right? And when it's you who's sick or your child or your parent, you start thinking very differently. If it's a loved one with an incurable cancer, you want somebody to spend every penny under the sun to keep them around for a month or 2 months or 6 months. It's heart-wrenching to think that that's actually, you know, what people are up against here. But I would certainly encourage that all of the stakeholders need to kind of do their part. I think we need to get incentives much better aligned so that all of the different actors right now are financially incentivized, because that's what it's going to take. It's an industry and a market that they are financially incentivized to follow the evidence and get right care to the right patient, right time, right place, right price. Sounds simple, there's a lot to it, but every single actor in this can do much more to getting to that right care than they are today.
So Cece is much more articulate than I am going to be, but I bifurcate the market into brands and generics. Let's talk about the brand market. So within the brand market, really, there's two types of medicines. There are medicines that really lack competition because they're unique. They're sort of precision-type medicines, which Christine's groups can't really compete. There is no competition to be able to retract any kind of concessions. In those cases, I think as industry, and you heard it last week again, we need to get into things like outcome-based contracting, which is going to be key so when you ask something that the Congress can do, yes, there are rules and regulations that prohibit some of these things happening. So pharma companies need to put their money where their mouth is, and if the drug doesn't work, we don't get paid.
Right.
Simple as that. I mean, let's not make it too complicated here. There are diseases that you can manage the outcome in a short period of time, so it's not like something that we need to look at 30 years down the line. It could be within a few months, within a year or two, with regards to cancer survivorship or something like that. We can do that. So that's number one thing. On the other side, when Cece's comment is when everything is aligned, things make sense, right? Incentives are aligned, things make sense. I'll give you the example of biosimilars again, going back to the issue of rebating and biosimilars and everything else, and the rebate trap that was spoken about by my colleague from Lilly. In the general market for biosimilars, we have Inflectra and Renflexis versus Remicade in the treatment of autoimmune diseases. In the general market, Renflexis and Inflectra have 5% market share total. In an organization that Cece actually represents, Kaiser Permanente, where incentives are aligned, those two biosimilars have 90% market share. Why is that? That's the question we should be answering. Where incentives are aligned in the market, people do the right thing.
Now I'm going to have to be nice to Bob after he just said that. Thank you.
I love
That's
Kaiser.
the model. That's the model we love.
We're going to have a
Thank
grand
you, Bob.
agreement on healthcare by the end of this panel.
Nobody has called me Bob since my chemistry teacher in high school, but that's okay.
We have 5 minutes left, so I want to get at least one question or maybe two. If you can identify yourself and ask your question.
Hi, good morning. Thank you. It's a great program. Kat Davis Ahmed from the Familial Hypercholesterolemia Foundation. I agree when the incentives are aligned and when every stakeholder is doing their part, I think we'll have a better outcome. So when prices, as you identified as a challenge, when prices come down, for example, in the PCSK9 inhibitor market. They cut the prices by 60%. Can you explain to me why some plans and PBMs have chosen not to offer their patients the lower priced drug, including in Kaiser Permanente? We hear from patients who are still being given by their plans the higher priced drug and paying the higher cost out of pocket for those drugs.
So I'll start. So the way that our companies negotiate is to get to what they call lowest net cost. And what that means is that whatever the starting list price is, and this is why prices actually matter, whatever the list price is the price that is negotiated off of. The reason that our companies end up with rebates is that the manufacturer settled a class action lawsuit 22 years ago that basically they said, okay, we won't do upfront discounts anymore. We'll give the same discounts to anybody who proves they can move market share to our product. So you can only prove it after you've done it. So the rebates are done after the fact, and the rebates typically by contract are passed back through to the insurer, and the insurer figures out what to do with them. The insurers, in my opinion, use them to help with their benefit structures. We've moved to a system in which a lot of people have high deductible plans, which I think goes back to Cece's issue of we really need to talk about insurance in this country. And so the PBM is getting for its client the lowest net cost for a given drug, and that is its job, and that is what it is doing. And so the situation that those patients are in, would everybody prefer that the patient be able to get a drug that's priced low to begin with? Yes, but that isn't the system that we currently have.
Yeah, and I think that Commissioner Gottlieb actually sort of underscored this earlier this morning when he was talking about rebates. And he made the observation that, in fact, the rebates are typically used by plans to reduce premiums. So, again, we're all paying one way or another way, and where you sort of distribute that, you can have conversations around. But there's a lot of desire in this country right now from Americans that want to have affordable monthly insurance premiums. So there's also that pressure.
That's the big question, right? It's in Medicare Part D, the rebate is used entirely for the premium. Mm-hmm. What happened in Medicare Part D was the plans discovered over the last 10 or 12 years that that's what the seniors were buying on, seniors and disabled people with disabilities. What we need to have is a conversation, and I think that's what the Secretary has opened up, is a conversation about what is the appropriate use for price concessions. Is it to use them for premiums? And I think probably a lot of insurers also take those into account when they're designing their cost-sharing tiers and how much each tier is going to be. They're thinking about, I'm probably going to get X amount of rebates. I don't know quite for sure. So I'm going to have generics be $10. I'm going to have preferred brand be $50. I'm going to have, so they take those into account when they're setting their tiers. But we do need to have a conversation about how best to reflect those. And we also need to have conversations about list price, because the list prices are hockey sticking in the brand world.
Robert, you want to weigh in?
Yeah, so we can have a debate whether the best way to contract is rebating or upfront discounts, which somebody like Kaiser does. They don't do rebates, right? So we can have a debate about that. But the bigger issue is that why can't we pass these concessions directly to the patient at the point of sale who's using these drugs? Because in every other segment of healthcare system, whether it is the physician services, whether it is hospitals, whether it is dental care, patients benefit from negotiated prices. So I'll give you my own personal example. In my dental plan, we have to pay co-insurance for any kind of fillings or things like that. So during the summer, right before vacation, I had an emergency filling I needed to do. I went to my dentist. They put my insurance information in there. And I ended up paying 50% of whatever the cost was. But it wasn't the customary cost of the dentist. It was actually the negotiated price that was done on my behalf that I paid based on. So that's the key here, is that if patients who show up at if we're going to stick with the rebating, which is fine, then if we can just transfer all of that to the patient at the point of sale, who it's been negotiated for, I think that will be a better model than we currently have. And then we can have a larger discussion whether or not we should do an upfront discount like Kaiser does, or go to a system like with rebates that currently exists.
We have run out of time. I really enjoyed the discussion, and bottom line, no one got hurt. So I thank the panelists. Please thank them, and I hand it back to Jack.
And that's a good thing, Bob. Thank you to our panelists for that conversation and to all of today's speakers. This brings us to the end of today's program. And on behalf of The Hill and our sponsor, Eli Lilly and Company, I would like to thank you all in the room and to those who tuned into the live stream for joining us this morning. If you missed any portion of today's discussion, the full event video will be available on thehill.com shortly. We encourage you to keep the conversation going on social media using the hashtag TheHillRxAccess. Thank you for joining us, and enjoy the rest of your day.